Good afternoon, everybody. I'm Claire Snyman, first and foremost a patient and also the chair of Networked Health BC. And I'm really excited to be here with all of you today and to help guide our session. I just want to bring up the slides so we can get started. But first of all, what I'd really like to do is to acknowledge the traditional territory from where I'm calling in from. For thousands of years, it has been the traditional land of the Musqueam, Squamish, and Tsleil-Waututh nations. And today, this land is still home to many Indigenous peoples from across Turtle Island. And I'm grateful to be able to have the opportunity to work and live with my family on this beautiful land. So maybe everybody can just take a moment to acknowledge the lands from where they are calling in from around Canada. I know we have many people from many places today. So thank you very much. So let's get going. Firstly, thank you for taking time, for joining us today, wherever you are, whatever time zone you may be, for your interest, your passion on this topic of health data design and use in Canada. This is actually our very first webinar. This is a bold step for us. We've had a lot of curiosity. We've had questions about who we are and what we do. And so we thought this is a great way for us to actually share that information. And so we're learning today as we sort of do this. So fingers crossed for a smooth hour together. Today, you're going to hear from our executive team. So that means the co-chairs of the various networked health chapters across Canada, and they will introduce themselves to you along the way. So what can you expect from today? Well, firstly, we're going to start with the why, a few stories and perspectives to ground us in this work. We're then going to talk about the current challenges we're facing in Canada and how networked health has started tackling them. After that, we'll open it up for your questions. And for questions, we're going to be using Mentimeter. Now, you may have seen the QR code earlier when you logged in, and it's up on the screen again. So please take note of that. And it'll be open for you for the whole duration of the webinar. We had a question, the first question, which was up if you joined a little bit earlier than the time we started the webinar for you to answer. And that particular question will be open for the next while. But please feel free to drop any additional questions you might have as we go through this hour together into the Q&A section in Menti. And we will address them at the end, along with some other questions we will be asking. So let's get going. This hangs up in my office, just up here to the left of me. And I love it because it reminds us of where we started. And today we're going to start off with a few stories, those different perspectives to ground us in the why this work actually matters. And I'm sure many of you can connect with that why. It might be why you started the work that you do, or actually why you're here with us today. One story in particular stands out. It's the story of Greg Price that's shared through the documentary Falling Through the Cracks from Greg's Wings. And it is a very powerful reminder of why health data design and use in Canada must be a priority. And we're fortunate to have Terry here with us today and in our work at Networked Health. So we're going to start, I'm going to stop sharing now, but we're going to start our stories today from Northern BC, from obstetrician gynecologist Dr. Carl Severson. And Carl is one of our co-chairs here in Networked Health BC. He can't join us today. Carl is actually on call, but he was very kind and made a video for us yesterday. When health data gets to the right provider at the right time, and when data flows seamlessly, providers can make faster, safer, and more informed decisions, which directly improves patient care, as well as impacting their own well-being. So I'm going to pass it over to Carl to introduce you to his perspective.
Hey everyone, my name is Carl. If you're watching this, it's because I'm on call and I've been called away, which inevitably happens when I'm supposed to be at these things. I work as an obstetrician gynecologist in a rural setting in northern Canada, and here I can see and feel how the lack of health information affects people every single day. I suspect Ewan probably told you a story about flying someone out of northern Quebec because a specialist couldn't see the images. Well, I'm here 30 plus years later, and this is improved, but it still happens all the time. A few weeks ago, I had to muster up a helicopter, a pilot, and a transport team to bring someone from a little small island over to me so I could assess them emergently. And in this case, that person was fine, but had I had the information I needed about them, I wouldn't have needed the helicopter. And that information was totally there. It was stored in systems that I didn't have access to, and that the person transferring the patient didn't have access to. A helicopter was a lot of resources for the system to use. It's a huge disruption to that patient's life. But ultimately, in that specific scenario, I could only do the best I can with the information I had. So it was the right call. But the whole time that helicopter was in the air, I was just crossing my fingers and praying that someone else didn't need it. Like, what if there was a preterm baby delivered and I had the chopper in the air for 6 or 8 hours because of this other patient, right? Like, that could be life or death for a preterm baby, or for someone with a stroke or a heart attack or myriad of other things. And we make decisions like this every day, often in an information vacuum, and we just have to do the best we can. If you want another example, like just a couple of days ago, I was talking to one of our cancer surgeons about a patient, and just by happenstance, they mentioned that when they order a CT scan for a patient where I'm at, they don't get the result back. They have to get their staff to manually go and look for and find the result. And this has been going on for well over a year, that this kind of expanded cancer surgery setup has been happening. Can you imagine what it is like to be a patient and have your cancer care delayed or otherwise affected because of something like this? Unfortunately, this thing happens all the time. It's actually so common, it's normal and normalized. And clinicians, patients, policymakers, administrators, no one really, myself included, understands the extent of this problem. And this is not a technology problem. There's a technological component to it. It's not a technological solution. There's a technological component to solving it. But when this kind of thing happens and you dig into it, it's almost always due to human factors. It's about how our laws and regulations, our privacy rules were written, our policy or lack of policy. It's about how we organize ourselves and how we work together or don't work together. The technology is the easy part. It's those other things that are hard. And ultimately, like, as a clinician, the quality of care that I can provide is dependent on the quality and availability of the information I have about someone. If I don't have your labs or your images or your documents, or if I can't get them to where they need to be, I can't enable you to make decisions about your care very well or get you the care that you need. Which means that for me as a patient, I can't get the care at a quality or level that I need or to survive there, because we're all ultimately patients.
Thank you for that. And we wanted to play the whole clip, but we might get around to finishing that later on. But I wanted to just thank Carl for always just reminding us of why timely access to health data is integral to our healthcare teams for when they are treating us, really as patients, to ensure the provision of safe and quality care. So I'm going to bring up a slide. Actually, this is of myself. I'm going to provide a little bit of the patient perspective and why this is really important. So let me just get that slide up and going. Here it is. So this is me. This is me in my healthcare binders. Now, this photo was taken last year, and it does not include any records from my GP, because that would probably be another 2 binders. My own journey with the healthcare system, gosh, it began as a teenager many years ago and long before the internet. And like many of you, healthcare became woven into the fabric of my family's life. But over time, I went from, the occasional check-in to living with multiple diagnoses, 5 specialists, a very regular GP, and daily medications. Now, Each of those encounters generates data, information, what I call my patient story, my story. But that story has never existed in one place. It has always been fragmented for both me and my healthcare team. And that gap has come into very sharp focus um, in 2010. I was diagnosed with a non-malignant brain tumor at the age of 34. My son was only 4 years old. The treatment was wait and watch, meaning no surgery, just monitor it every year. But it became very clear almost immediately that I had to be the custodian and the manager of my own health information. There was no single source of truth, per se. There was no seamless flow of information between my providers. So that's when I started my binders. And in fact, the little red binder that you see in there is my brain tumor binder. 2 years later, worsening symptoms landed me in the emergency department. And I carried a piece of paper from my GP about what was going on, but that sheet could never capture the full complexity of my journey. My records weren't moving. My providers that were seeing me then weren't seeing the same information. And it was, I suppose, in many ways, you could say, like a dangerous game of broken telephone. And because of that, the signs of hydrocephalus, which means I had swelling in my brain because my tumor was blocking the flow of fluid in my brain, was missed. So I was sent home with migraine medication, but I was incredibly sick. And I am here today, but really only by luck, I would say. And the physical and emotional toll of that gap in communication was enormous. And that is why the flow of data and interoperability, as we call it, is not a nice to have, it's a necessity, because every missing piece of data is a missing piece of a patient's story. And without it, as Carl already said, providers are working blind, and patients like myself and our families and support people bear the consequences. And even now, I still have all my binders in my closet, paper records. I have my own Google Drive to keep track. We have provincial patient portals and they hold promise, but they remain incomplete. So until interoperability is fully realized for me as a patient, that burden falls on me, my family, my support people, and the care team caring for me. So I'm going to stop my slides now and we're going to just move to different stories and take you through a few different areas, because what I've learned very much so is that health information and the flow of it does not just affect patients, right? It impacts my providers. We heard from Carl, my care team, but so many other areas of healthcare, because the way information moves can shape experiences, outcomes, and decisions. So let's take a look at what that means. So Phil, I'm going to pull you into this because when we think about it, innovation is such a vital part of Canada's economy and infrastructure. But from what we're hearing, it often runs into roadblocks because systems can't connect, data doesn't flow the way it should. So, Phil, I'd love to bring you on stage for you to jump in here, for you to introduce yourself and share your perspective on this.
Absolutely. Thanks, Claire. So I'm the chair of the newest chapter of Networked Health Ontario. I'm an engineer and researcher by background. I manage the Health Data Innovation Program for Innovate, and that's an organization that represents and supports AI and image-guided therapy research and development of companies and academic institutions across Canada. And so while I'm working with Networked Health, I take off my Innovate hat. But the experience and insights that myself and others bring to the table from our work and our roles outside of Networked Health, whether they're patients like Claire or clinicians like Carl, are crucially important. And so one example of the work that I do is on access to data for innovation and medical technology. And so we have a huge opportunity to translate Canada's strengths in AI and medical technology into a thriving health AI technology innovation ecosystem that can have profound impacts on patient care. But what many outside of research or industry probably don't think about often is that the algorithms that underlie these technologies require high quality data, and that data needs to respect the diversity of Canadian populations. Otherwise, it may not function well in Canada and potentially even cause harms. And I can say that there's a great deal of frustration throughout Canada in the health technology industry when it comes to health data access. The data often resides with health information custodians, often hospitals and other healthcare institutions that are reluctant to share data with the private sector for innovation because there's a lack of public trust that sharing data with industry for technology innovation is being engaged in responsibly. There's a lack of awareness about the need to share it, not only by the public, but by those same custodians. And this has led to a lack of guidance and a lack of acknowledgement of the need to share data for innovation and public policy as well. So as a result, the current environment is inconsistent and inefficient for data sharing. Technology and innovations that would be of direct benefit to patients and the public are being frustrated or delayed. Networked Health has identified the failure to support health technology innovation as one of 9 health data related harms. It harms patients, diminished access to potentially transformative technologies, the health technology industry that are in some cases actively disincentivized from engaging in collaborations with health Canadian academic clinical partners, and the economy as funds and partnerships flow to the country. And what data sharing there is often happens without adequate oversight or transparency, which has damaged public trust that healthcare institutions are behaving responsibly with their data. So the key point here, I think, to recognize is that the underlying causes of the dysfunctional data sharing environment for innovation are shared with those of the other harms that have been mentioned by Carl and Claire and will be mentioned by others. Innovation is disrupted by lack of interoperability, siloed data, poor quality data, lack of governance, transparency, guidance, unclear and inconsistent policy environments, and a lack of public buy-in and trust. So hear about the work that we're doing in Network Health. That will have direct downstream impacts on Canadian innovation and the Canadian health technology industry, and ultimately on Canadian patients. And it's already begun to influence policy direction. Network Health is formed as actively seeking partnerships, including those with my organization, Innovate, and the work that we're doing with Bill C-72, Digital Health Canada, and others that are representing innovators in the private sector. So change of the scale requires a buy-in and co-design with partners across the ecosystem, including those of industry. The knowledge that industry and other innovation leaders provide is essential to ensuring that recommendations and strategies reflect system realities. Where they're addressing innovation harm or any other harms, this all comes back to improving healthcare for Canadians. So I hope that you'll join us in helping to make real lasting change in the health data environment in Canada. Thank you.
So thank you. I really appreciate that. As a patient, when I started out thinking about the health data, I thought it was all about me, and that sounds selfish, but you think that patient data relates to patients and in the care team, but there's this much bigger tent under which health data is so critical. And as you've just pointed out, that innovation, that private sector, that policy, there's so much more that we need to be thinking of. So thank you for really sharing that. I greatly appreciate that. And I want to bring in Anne. Anne, you have such a unique perspective, especially when it comes to that system and the administrative challenges that we're all grappling with. So I'd love to hear from you if you could introduce yourself and share some of those insights with us today, please.
And thank you, Claire, and hello, everyone. I am the co-chair of the Ontario chapter along with Phil, and you'll get to know a little bit about me as I share my very specific story with all of you. I want to just start by saying that we have a lot of work to do across the digital health profession to come together around some common goals. And by digital health profession, I don't just mean the software developer who's building an EMR or a standards expert or an interface engineer. This includes our clinicians, our lab techs, our registration clerks, the myriad of people who are involved with a patient's care and who are now also responsible for documenting digitally in an accurate and timely manner. So for some background, I spent my career in government agencies and in roles that were arm's length from the delivery of care. And a couple of years ago, I decided to move into a hospital setting to really get a handle on what the issues are. What is preventing us from achieving interoperability for multiple purposes, including clinical care, population health, research, and innovation in this country? After 2 years of managing and optimizing the EMR at my hospital, I can say for certain that the problem is not related to our technology, to echo what Carl was saying earlier. It is a complex array of a deeply entrenched culture that's resistant to change, workflows that have simply been replicated from the paper world rather than optimized for the digital world, and a severe lack of digital literacy on the front lines. These are problems that we can solve through leadership and a collective movement towards the same end goal. The story that I'll share with you is about patient access to data. Now, we all know how important that is because it can help patients manage their own care, catch gaps or inaccuracies, and feel more informed about their treatment plans. So at our hospital, we make test results available to our patients through a patient portal. And over the course of the summer, we've been working towards making clinicians' notes for all scheduled visits available in that portal as well, because these often contain important details about the patient's condition or treatment plan. Now, despite knowing how important access to this information is, and a general agreement that we want to be transparent with our patients, the anxiety that we came up against as we prepared for Go Live was very real. But we worked through it, and it took daily concentrated energy. We held the meetings, the elbow support sessions, the leadership rounds, provided supporting evidence, answered the same questions over and over again relentlessly. And finally, we achieved it. Not just mere acceptance that we were going to move forward with this project, but support, championship, and real buy-in to the Open Notes movement. And as a happy byproduct for me, we achieved a much deeper understanding amongst our clinical users of our EMR of the implications of the technical setups, where the data in the EMR lives, how it flows, increased comfort with jargon that would have previously just been considered a problem for the tech team to worry about. And once this knowledge becomes second nature for everyone in the digital health profession, including clinicians, that's when we can truly start to unlock the power of technology. So this is just one example of countless projects that are happening across the country to help advance the digitization of health. These projects are difficult to navigate, but having that guiding North Star, a reminder for why we're doing this, and a collective action group supporting the journey every step of the way, that's how I think we're going to make some real progress.
Thank you, Anne. And just thank you both to you and Phil for sharing these perspectives, which I think really bring the why to the front and center of this conversation today. And so we're going to shift focus a little bit now as to how we at Networked Health here have begun addressing some of the challenges we've heard about already. And a reminder to put any questions you may have into the Q&A Mentimeter so we can get to those later on. So Ewan and Glenda, we're handing over to you. So please go ahead and introduce yourselves and take the stage. Over to you.
Thank you very much, Claire and Phil and Carl by video. So my name is Ewan Affleck, and I'll hand over to Glenda in a moment here. But I've been with Networked Health since sort of the inception of this, when it was a little baby idea. And I'm going to talk a little bit about how this came to fruition, how it started, and a little bit about how we function. And Glenda and I will tag team here. And so for those of you who don't know, I'm a clinician. I'm a physician, but I also, and I do a little bit of clinical work, but I largely work in the digital health governance and public policy space. So I will start here, and I'm going to tell you a story. So we've all been telling stories, and we think stories are important. And this goes back to the inception of my career, and this will help explain why we got to where we are today with this, with our collective movement around health data in Canada. So this. And you can tell by my lack of hair, I'm the grand old man in this organization. And I started my career after I finished my degree at McGill in Salowit, Quebec. And this is in 1992. And this is a picture of Salowit, for those of you who've never been there, which is probably most of you. It is on the Hudson Strait. It's a little Inuit community. It's on the tundra. It is quite spectacularly beautiful, but quite a cold in the winter. This is where it is. So it's on the Hudson Strait opposite Cape Dorset. And I was the first permanent physician there ever. Before that, it was strictly fly-in, and I would cover all the patients on the coast of the Hudson Strait up north. And one day a child was brought in to me, and this is a picture of the not of the actual child, but for those of you who don't know, newborns have sutures. They have cracks in their skull that allow the child to the skull to mold in the birth canal as it comes out, and then they fuse later. So this was a child of about 6 weeks old that had fallen out of a carriage onto a concrete step. So they were brought in, and in the nursing station, the janitor did the x-rays. So she did an x-ray, and I looked at this thing, and there were these lines, and they were perfectly symmetrical, and I could not tell if the lines were sutures or were bilateral skull fractures. So my choice was to either medevac this child for, I don't know how much it was at that point in time, $10,000 to fly them to Montreal for sutures in their skull, which are normal, or if the child had bilateral skull fractures, which put them at risk for an intracranial hemorrhage and possible death. So I brought out my textbooks and had a look, but I had no means at that point in time to send these images to Montreal. And in fact, what I did was I traced this on a piece of paper, and I faxed it to the radiologist, whose conclusion was that I was terrible at drawing, and they could not tell, which is ironic because my brother is an animator and everyone is in film and painting and so on, but I suck at it evidently. So I didn't know what to do. So I concluded, based on these old textbooks that I had, that the child did not have a skull fracture. I kept the child. The child did fine. Film was sent out by Twin Otter, returned 10 days later from the radiologist in the south on the plane, and the child actually had a bilateral skull fracture, which I had missed. Now, fortunately, the child did not die. But I was like, this is crazy. And this is when it became evident to me that we should have the option then to transmit information, which can then inform people, wherever they may be, to the person with the knowledge and resources to make that decision. So it dawned on me that clinical services are completely dependent on information management and coherent access to information. So we largely depend on planes and internal combustion engines to move people, where we could actually be moving information much more efficiently. And as Anne and Phil have pointed out, this touches far more than clinical services. That's where I come from, much like Carl. So, the question is then what happened, and I see the number got screwed up here a bit. So I now do my clinical service in Yellowknife, and here we are 33 years later, and our information does not flow between the two jurisdictions. Nothing has really changed in 33 years. I mean, I shouldn't say nothing. Many things have changed, but for the most part, jurisdictional continuity or interoperability of information still does not exist in Canada a third of a century later. And if you told me back in 1992 that this was going to be the case, I would have said you're crazy. But it continues, and it is deeply fragmented. It is damaging Canadians. It is damaging our capacity to provide care. It is damaging research. It's damaging innovation, as Phil has said. And we're still, in 2025, largely reliant on the fax machine, which is what I used to transmit that picture I drew 33 years ago. Now, if that doesn't seem crazy to you, then it's crazy. So is there a problem with the technology then? Is this a technology issue? Can we integrate technology in a way that allows this to occur? Absolutely. It is not a technology problem. The problem, sorry, I went ahead there. The problem really lies with how fragmented, and the others have made reference to this, how fragmented we are in Canada with respect to our approach to health policy, health data governance, and our ability to work together, right? And this is a manifestation. Claire pointed to Greg's story, and Terry will be here. She's my co-chair on Networked Health Alberta, Terry Price. So this is a picture of her brother's care in 2012. And all these are all different databases and the information flowing between. So he had like 13 different databases in his care that were not joined. And if you map this today, it continues to happen, that these databases are often not interoperable. And so we at Network Health decided that we needed to reinvent or invent a way to begin addressing health data policy and governance. And we began producing content. And this is our first report. It's called Interoperability Saves Lives. And in it, as Phil made reference to, we proposed this harm framework, and we pointed out that there are all kinds of forms of harm that arise from our lack of ability to function optimally together. And so I'm going to ask you, what year, this is a rhetorical question, was health data interoperability legislated in the United States? And the answer is 9 years ago in 2016. And in fact, they began preparing for this in 2004. So they've been on this path, creating the Office of the National Coordinator for Health Informatics in 2004, so 21 years ago. And we're still struggling with this in Canada. And so in Canada, the answer to this rhetorical question is, what year has this happened in Canada? Well, it hasn't happened yet, although was an act introduced recently that died when the recent election was called. So we are harming ourselves in Canada very successfully by not working together and integrating this. And it's a complex problem because the palette is people, and the palette is governance, and the palette is literacy, and the palette is our capacity to work together. And that's why we in that way we say, what is the problem? And it's a relational problem. We can solve this, but we need to begin working together, right? We do not have a technology problem. We do, but the technology problem is a manifestation of our relational problem. And we have to stop investing in technology and realize we have to invest in our capacity to cooperate with each other. Because currently we're going in multiple different directions simultaneously, and this doesn't work. So I'm going to turn it over to Glinda here. And we call this, incidentally, human factor interoperability. I'm going to turn it over to Glinda and talk about how we aim to address human factor interoperability, or our ability to work together, because that fundamentally is the premise around networked health. And so we use something called collective impact. It's sort of been an abused term. Everyone sort of claims to be doing this at times, but we have actually been fairly fastidious in our efforts to adhere to the principles of this model. So, Glinda, over to you.
Thank you. Thank you, Ewan. So I'm Glinda Rees. I am the co-chair along with Carl and Claire as the chair of the BC chapter of Networked Health. I'm a nurse by background and appreciate being here today with all of you. I am going to talk a little bit about the actual work that Networked Health is doing. And as Ewan was saying, if some of you may be familiar with this diagram, it's a collective impact model that isn't always used in its truest form. That is our intent, is to use it in its truest form. The definition comes from Stanford in 2011, being that the commitment of a group of important actors from different sectors to a common agenda for solving a specific social problem. And it really calls for cross-sector coordination rather than isolated impact or a solution implemented by an individual organization. And it's instigating social change rather than organizational or individual change. So we're really looking at social change here across Canada. And so what we're doing is bringing together people from multiple perspectives and insights towards the same goal, guided by the same principles. And I'll talk a little bit more about that. But our goal is access to comprehensive health information, because we know that it's the key to safer care, smarter innovation, and to improving health for people across Canada. We always have our patients at the center, as you can see from the diagram, and patients are part of the whole team approach. And we bring a non-partisan, apolitical, free of organization. We free ourselves of our organizational strategic priorities and work towards this collective impact. that is more than just collaboration. It's really just that commitment of bringing different people together from different parts of Canada with different expertise and insights, working towards this goal. And we base them on the principles that come from the Pan-Canadian Health Data Strategy. So it's very much about leaving our head at the door, coming to this work with your expertise, your passion, your energy, and a commitment to respect and kindness that aligns with the principles and the vision that we have set as a group of committed individuals at Networked Health. So the common agenda is based this. So this is the first step of the collective impact approach. And our common agenda is based on the principles of the Pan-Canadian Health Data Strategy, all which came out of the Pan-Canadian Health Data Expert Advisory Group led by Dr. Vivek Goel and supported by the Public Health Agency of Canada. And this Health Data Charter and these principles were endorsed by all the provinces and territories, apart from Quebec, in October of 2023. And so we have these principles that we align with across Networked Health, but we are also customizing them to each of our individual provinces and territories. We also have a shared measurement system. So we're looking at governance. We have a clear governance structure and framework, and we evaluate how we function as a group, how we function across the network. We have several projects. We have 8 ongoing projects right now under our working groups that all align with the principles, and we measure and look at the outcomes of those principles and of those projects and their impact on the health system that we're interacting with. And we're doing this continuous quality improvement loop as we move through this work. The third piece of this is ensuring that we are doing mutually reinforcing activities. Ewan and I think Claire also spoke to this at the beginning. Through the Networked Health website, you can access these reports. So interoperability saves lives, data disarray, and disconnected care, all of which are really speaking to the challenges that we face across Canada and align again with the work that we're doing and the sort of action of what we're, the action of the principles that we're bringing through in the work we're doing. The other important piece of all this work is to ensure that we have continuous and transparent communication within ourselves and to everyone across Canada. So we're working with the University of Calgary on some branding. So you'll notice that we now have a Networked Health logo. We used to be a little bit more, we had more individual sort of branding, but now we're coming together with our branding. And we are also working on sharing what we're doing through webinars such as this one today, through social media, and we'll be sharing a LinkedIn link for you later, so you can follow us on social media. We're going to be starting a newsletter, so you can sign up for that as well. So lots of activities and lots of communication to share what we're doing. And then the final and feasibly most important piece of what we're doing is the backbone support. So we have a secretariat that is funded by several different sources across Canada, and we bring in students, grads, and students who are currently students and who have also graduated, who are and are early in their career. They usually start as volunteers, and then we bring them on in a more formalized role with some funding, and they are critical to supporting the work that happens that underlies everything that we're doing and kind of keeps us all on track and coordinates all of us in the work. And you can see they come from different disciplines across the digital health sector. And as Anne was saying, under digital health, we have many, many different disciplines and professions, and always including the patient. And we meet weekly to coordinate the activities that we're doing. And some of us, sometimes we're meeting more than weekly because we have small groups doing specific work as well. And we're always looking to create that safe space for creative thinking and definitely thinking outside the box, but encouraging that at all levels. And then the last piece, just to speak a little bit about the growth. So we started, this work started in Alberta with Ewan and Terry, has grown considerably in Alberta. They produced those 3 reports we spoke to. In BC, we've been up and running for a year under Claire's leadership, and our group has expanded considerably. We have 3 of our own working groups at the moment, and I think Ewan will speak to those in a bit more detail, but we do have, at each chapter level, we have a coordinating body. Phil and Anne are leading our new chapter in Ontario. That's quite recent. And we make concerted efforts to ensure that we're coordinating our activities across our different chapters. And we are looking to welcome and if looking for more chapters, and if you're interested in starting a chapter in your province or territory, please reach out and we'll provide some connection opportunities for that as well. And I think I'm back to you, Ewan.
Sounds good. Thank you, Glenda. So I'll just very briefly, because we want to open this up for some questions and discussion. And one thing Glenda said is, first of all, this is all just Canadians that are passionate about making this better. All of us sort of have day jobs. We check our hat at the door. We join together to try to make this better across disciplines, across domains, across locations in Canada. And it has become quite powerful, this capacity to, once you begin cooperating and trying to move everything in the same direction, creating a safe, creative space for us all to work on this, to make Canada a better place, is fundamentally what this is all about. These are 3 of our early projects, and they've had an impact. We'll get into that in a moment. We have many other projects in course. We have about 10 reports coming. We're building a health data interoperability model. We're working on an Indigenous data sovereignty project. We work with Indigenous groups. They're part of our groups. We do not claim to be an expert about this, but we just want to represent what's currently happening in Canada. We're working on a roadmap as a follow-up to interoperability saves lives, on how to actually create an interoperable environment. We're looking at our health data related harm project and validating it. Phil made reference to that. And and I won't go into, but we're doing virtual care mapping. That is quite fascinating project under Glenda, where we're mapping patient and provider experiences together. There's a lot of things coming. We expect to publish maybe about, optimistically, 5 to 6 reports this coming year. And we have many, many partners who are working with this, and these are just some of them. But we work very closely with InfoA and CIHI, with Health Canada, with certainly for our initial reports with Alberta Health, and we'll expand. We will work with any government, we'll work with any group, we'll work with anyone. We like to say we're desperate for friendship. It doesn't really matter as long as you're committed to work together for common good. That's the thing. And we just try to do so cooperatively and based on our principles that we set. So let's talk briefly about a little impact we've had. Frankly, when this was a little baby idea many years ago, I did not think it was going to be where it is today. This is Terry standing next to then Minister of Health Mark Holland when the Connected Care for Canadians Act was introduced. So they invited Terry and I to come to introduce that bill, citing both the work of Greg Swings, which is an important partner and contributor to all our work, as well as the work we did around interoperability saves lives, is helping shape and allow the government to more comfortably introduce this work. It was easier when they said there's a community-based organization out there saying without interoperability there is harm occurring. So that was excellent. So that's the story around Bill C-72, and we're currently working with multiple partners on looking to reintroduce it. This is just another example. This is the CIHI website, and they said featured material on connected care in Canada. 2 of the 3 reports are reports from this funny little network health organization. by the way, we used to be called Alberta Virtual Care. We have rebranded, as Glenda says. We are working internationally, for instance, with Mount Sinai Hospital in New York City to validate our harm framework. Disconnected care as well has had an impact with different provinces and territories who have reached out to us about how to reconsider how health information acts are written. And we're working on a health data interoperability maturity model. And this was the Provincial Health Services Authority in BC came to us and said, we really like the way you have considered interoperability as both a human and technical issue, and we would like to build a model. So this is well in course, and with the cooperation of CIHI and Infoe and others. So it's amazing what you can get done when you work together with people. So to finish off, you go back 33 years ago. We don't want to still be stuck in 1992. Things have changed. We do not want to be held in place by the interprovincial trade barriers to health information. What the current government and what's happening in Canada, and this isn't an endorsement of any given government, but what has become evident to Canada is we have barriers to our capacity to work together, whether it be free trade around goods and services or trade around health information. It is a problem. And it's not only a problem between provinces and territories, but a problem within provinces and territories. Canada will be a better place if we fix this, and we can. If we don't, there'll be more people like Greg Price that will unfortunately have bad outcomes. This is a picture of him. There will be more frustrated innovators. There will be more frustrated researchers. There will be more health service providers burning out. You get the picture. So I'll turn it back to Claire. Thank you very much. I appreciate your time.
Thank you both. Thanks, Ewan. Thank you, Glenda. Thank you for that really great introduction and overview to the work that we're doing here at Networked Health. At the same time, we also know that there's a ton of people working across Canada towards the same goals and the same outcomes as we are. And so we love hearing about the work that you may be doing out there and how we might support it and work together. So please feel free to let us know about that. So we're going to move over to the fun part. It's your turn. I'm going to hand the mic over to all of you out there in the audience today. Let's head over to Mentimeter. So we're going to put that QR code up. There it is over there. So feel free to put any questions in there. We've got a couple that have been popping up. I've been watching the Q&A. But at the same time, what we also wanted to do is we're going to put 2 new questions up into Mentimeter as well. That you can answer those as well if you would like to. But we just given the time frame, we're going to dive straight into the Q&A and address some of those questions. So one of the ones that I'm actually going to pull straight out there, which is an excellent question, and actually I think you alluded to it earlier on, and I'm maybe just going to ask if you might help answer this question, Ewan, if you are able to. Is how do we involve our Indigenous populations in this drive for interoperability? They are hugely underserved. Ewan, I'm not sure if you are there and able to answer that question for us.
Yeah, I'm here. I do not claim to be an expert in this domain, although I have spent my clinical career working with Indigenous peoples. We have to work, first of all, we have to become literate about our constitutional and nation-to-nation obligations to Indigenous data sovereignty. So this is an obligation that has not been borne out in the way we have procured and deployed technologies. There's a great deal of good work going on in Canada by First Nations, Inuit, and Métis peoples on trying to navigate this whole notion of data sovereignty. And health data is a big part of this. So constitutionally at Network Health, each of our chapters includes substantive Indigenous representation. And as each of us as Canadians have sovereignty over our personal data ourselves, there's community-based sovereignty on the part of Indigenous people. So we need to turn to them to help guide this, and it needs to be an integrated integrated approach with other aspects of health data design and use. So that is my short answer for a non-Indigenous guy. I feel a bit of a fraud here, but so it's really about cooperation. So I'll stop there, Claire.
Thank you. I appreciate that. I'm going to dive back into some of the other questions, but Terry, I wanted to come to you because I feel like you and Ewan really brought together, as you said, with Alberta Virtual Care in the beginning, now Networked Health. So you've been part of this for many years now, and I wondered if you could maybe give us one or two key learnings that you might be able to share with us today, given that you've sort of seen the whole fruition of how this whole model and this whole network has really come around over the last few years.
Sure. Yeah, I think there's been a lot that we have learned over the number of years since Greg died. And one of the things that sort of stands out as a shift in the way that I was thinking about things was when we met Ewan, and we saw that Ewan showed that health information exchange map in one of the slides with all of the little bubbles of where Greg's information was. I think at that point, I was really focused on sort of pushing for patient access to information and thinking that it was critically important for patients to be able to, in order to sort of shift power and enable patients to be active in their care, they needed access to the information as well. But with those diagrams and some of what we've learned along with Ewan and lots of other people who are working in this sort of space, realized that it's not just patients that are missing information, it's the providers as well. And we really believe that safer care will be delivered in teams, and teams require access to information and the ability to share and communicate information in order to be effective and sort of high performing teams. And I think that's one of the things that we've also learned sort of at a systems level, is that there's a lot of people working hard that sort of recognize these issues from different perspectives, and a lot of people that actually are excited to be able to collaborate and work together to try and address some of this. I think now there's more of a recognition that it's not going to be one organization, one government, one like patient advocacy efforts that's going to actually cause all the change that we need to see. We have to be able to work together, and we're optimistic about how excited people are and the momentum we're building through this approach to try and address some of these issues. There's Anne.
Thank you, Terry. Appreciate that. One of the questions focuses in on talking or asking about, rather than sort of in trying to connect these health information silos that are managed by clinicians, why don't we look at how do we transfer custodianship of primary care records from physicians to a government agency to enable one record, one patient? I'm wondering if anybody has any thoughts they might want to add into that.
Yes. Okay. So I don't want to monopolize here, but this is a very good question. I think what you might be referring to is the stewardship model. The custodial model, and this is borne out in our work, particularly in data disarray and disconnected care. The custodial model of health information oversight actually very successfully fragments information between different services. And there currently is no obligation in most jurisdictions which use the custodial model to actually interoperate or ensure that data flows between services. So we're fragmenting patients' information. It's leading to harm. And this is legislated. So we are sort of, when you think about it, legislating the harm of Canadians. We need to rethink this. And what I'm happy to state, and we're working very closely with CIHI, who has been given oversight of a project by Health Canada to look at a stewardship model. And we are working with them and InfoA and Health Canada and local people in Alberta and others. This project is one of our Alberta-based projects to look at that. Exactly what that looks like. And I will also say that there's an international sort of movement afoot to begin rethinking this. So this is an excellent question. this is underway, and we hope you all can tune in and support this effort to reimagine a stewardship model of health oversight from rather than a custodial model.
I'm just keeping an eye on the time. I think we've probably got another time for maybe 1 to 2 more questions. There's 2 questions here that I think are sort of, in my mind, might be in parallel. The one is, what can we do when funding gets pulled from projects that were underway from interoperability? And right behind it is, how do Canadians reintroduce Bill C-72 into the current Parliament? So I'm wondering if there's any sort of thoughts or comments that anybody would like to share about that, about when funding gets pulled from projects, and anything about Bill C-72.
Phil, why don't you talk about your work around Bill C-72, or we can.
Sure.
Here.
So I'll mention the first question about funding gets pulled from projects as well. Just bringing it back to the exclusive impact approach, right? That's one of the benefits of the work that we're doing, that we're not particularly answerable to any particular mandate. We don't flow with change according to election cycles. We're a group of individuals that are working on this, that are dedicated to working on this continuously, right? So even though that these projects may have their funding pulled from particular departments, government agencies, we will continue working on this as we go forward. So in the Bill C-72 piece as well, so we have been in consultation with the government of Canada, the Senate of Canada, to provide our input, both in partnership with Innovate and Networked Health, on proposed updates to Bill C-72, and I think it's fair to say that we believe that this will be resubmitted to this current government as well. So we are actively, and Terry, you can speak about this. We're actively working on creating a partnership and collaboration around, what do we do with C-72 in terms of what changes do we believe should be implemented into a new version of this.
Yeah, and last week, actually, Networked Health brought together a host of organizations and individuals, and we can just send a note through our website is the best way to do this. We're all a little new at this. Terry is nodding. So we just sent to some partner organizations, people, and I had that slide with all the people saying, who really is committed to this. We invited around 6 people and 26 turned up. It seems to be unanimous in Canada that this needs to happen. And so if you or your organization support the reintroduction of Bill C-72, the more people we can collect. And so we are actively working on this. It needs to happen. So that's the short answer. So reach out to us.
Yeah. Thank you for that. I appreciate that. And I'm just looking at the watch and I'm going, oh my goodness, time has flown by already. We are at the hour. So I'm going to thank you for joining us today. We truly value your time, your insights. Thank you for all the Q&As that came through. And we really hope to keep, these conversations going. Be sure to sign up for our upcoming newsletter. You can look on our website, read, download our reports. Also, as Ewan said, if you'd like to connect with us on our About page, I think it's there. You can actually connect with us there. We'd love also follow us on LinkedIn. We are always looking for friends. So thank you so much for your time. Have a great day and take care.